My name is Jane Jerzak. I am the partner in charge of healthcare consulting at Wipfli Healthcare Consultants and CPAs. I've been with Wipfli for over 25 years, providing reimbursement, financial, strategic, and other services to healthcare organizations throughout the country. The discussion today is on value-based purchasing for critical access hospitals. The objective of the discussion is to gain a high-level understanding of value-based purchasing concepts for critical access hospitals. The discussion agenda: first, we will define the value-based purchasing concept in healthcare. Next, I will discuss the understanding of market trends in value-based purchasing, as well as how value-based purchasing concepts may be implemented in critical access hospitals. And finally, I will discuss how critical access hospitals should prepare for this new reimbursement methodology. The definition of value-based purchasing in healthcare. In October of 2012, the Centers for Medicare and Medicaid Services created the concept of the Hospital Value-Based Program to improve healthcare quality, including the quality of care provided in the inpatient hospital setting. Today, hospitals subject to the Hospital Value-Based Program include inpatient prospective payment system hospitals, not critical access hospitals or other specialty hospitals at this time. CMS now annually publishes a hospital-based value program incentive factor or payment adjustment factors. Based on the achievement of a defined set of measures, certain hospitals are able to receive incentive payment adjustments for inpatient services provided to Medicare beneficiaries. Since the program is to be self-sustaining, all eligible hospitals are reimbursed amounts from Medicare that reflect a withhold amount to be distributed as incentives only to those hospitals that are successful in achieving a sufficient performance score for incentive payment adjustments. The withhold amount for fiscal 2016 is 1.75% of inpatient reimbursement. That is moving to 2% in fiscal 2017. The hospital-based value program has 24 measures in 2016 relating to the following domains of quality and the domain weighting. Clinical process of care is weighted at 10% of the possible incentive. Patient experience of care is weighted at 25% of the possible weighting. Care outcomes are weighted at 40% of the total, and efficiency measurements are weighted at 25% of the total. In fiscal 2017, the number of measures decreases to 21, and the domain weighting is shifting more toward clinical care and outcomes, including patient safety and efficiency, and less on clinical process of care measures, which are decreasing to 5% of the total value. Given the success of the program experienced by CMS, including measurable improvements in many quality measures to date, certain large commercial payers are incorporating the concepts of value-based reimbursement incentives in provider contracts. We have seen commercial insurers provide incentives to providers to improve quality and efficiency of care through similar value-based concepts as adopted by CMS, with limited or no reimbursement increases as a baseline and incentive reimbursement increases based on measurable quality and efficiency improvement efforts that may range from 2 to 5% or more of overall estimated reimbursement. Some examples of quality and efficiency improvement incentives in commercial insurance contracts may include a reduction in readmissions for the population insured, a reduction in emergency department visits, use of lower cost settings of care such as ambulatory surgery centers, overall reduction in medical costs for the insured population. CMS has not yet adopted a value-based payment system for critical access hospitals where Medicare reimbursement continues to be based on allowable cost. However, in January of 2015, Sylvia M. Burwell, the U.S. Secretary of Health and Human Services, announced ambitious plans to move from volume to value in Medicare payments. CMS intends for 85% of all hospital-based Medicare reimbursement to be tied to performance-based metrics by 2016, increasing to 90% by 2018. There is concern in the industry that this goal will include critical access hospitals among the providers subjected to some type of value-based program. Industry analysts have reviewed the inpatient quality measures associated with patients at critical access hospitals throughout the country, attempting to project winners and losers should CMS adopt a similar value-based program for critical access hospitals as is currently in place for prospective payment system hospitals. Such analysts have suggested that potential winners under the current value-based program could include critical access hospitals in New England and in the western states. However, potential losers under the current value-based program could include critical access hospitals in southern states as well as in the Rust Belt. Historically, the ongoing challenge in creating a value-based program for critical access hospitals has been the relatively low number of measures and cases at these types of facilities. People are questioning how valid the measures are for critical access hospitals based on these low values. The National Advisory Committee on Rural Health and Human Services published a white paper entitled Value-Based Purchasing Demonstrations for Critical Access and Small PPS Hospitals in September of 2011 to address this very issue. The committee concluded the following. Critical access hospitals and low-volume hospitals will continue to need cost reimbursement if they are to continue to serve as safety net providers for rural communities. However, value-based payments can be used to enhance the quality of care and also the effectiveness of management while maintaining budget neutrality. Clinical measurements and performance should be based on relevant clinical quality measures with significant input from the critical access hospital community, peer comparisons, financial incentives to encourage participation, as well as technical assistance to be in place for the lower performing hospitals. Since the white paper's publication, a number of industry groups have taken it upon themselves to identify relevant quality measures for critical access hospitals. The Flex Monitoring Team, with funding from the Federal Office of Rural Health Policy, developed Policy Brief number 25 in January of 2012 that addresses relevant quality measures for critical access hospitals. Their findings indicated that a comprehensive set of quality measures are relevant for critical access hospitals, including those addressing appropriate care for inpatients with medical conditions, global measures addressing appropriate care among multiple medical conditions, and emergency department measures. Many of these relevant quality measures are now ready for reporting by critical access hospitals. Their findings also suggested that a single set of quality measures for all entities involved in regulation, accrediting, and payment would greatly streamline the process and reporting burden for critical access hospitals. And their findings also indicated that to motivate improvement in the quality of care and help patients make informed decisions about their health care, all critical access hospitals should publicly report on relevant quality measures. As a whole, Critical access hospitals understand that measurable quality of care, including outcome and safety measures, are important to the public and to payers. Therefore, the public measurement and reporting of relevant measures should be embraced by the critical access hospital community, since this is foundational for efforts to improve performance. As a healthcare board member or leader, part of your role is to ensure a strong system of reporting and accountability of quality for your organization. This includes making sure the right tools, technology, people, and processes are in place to gather accurate, relevant information on care, quality, safety, outcomes, and patient satisfaction. Report such information in a meaningful way to a designated quality team. Review the data and related findings with the quality team to validate and interpret the data. Create a prioritized set of process changes within the organization to improve quality measures and patient outcomes, and routinely measure and report relevant results for continuous improvement and adjustment. In summary, hospital value-based programs have been embraced by Medicare and other key payers as a method to encourage higher quality health care through reporting of quality measures and linking reimbursement increases to performance. Since Medicare's value-based program was adopted in 2012, CMS has reported direct improvement in quality measures as a result of quality measurement and reporting. Therefore, its role in healthcare reimbursement systems is increasing at a fast pace. It is expected that critical access hospitals will be required to participate in some type of value-based program in the near future as a result of HHS Secretary's announcement of ambitious plans to move from volume to value in Medicare payments. Critical access hospitals should embrace public reporting of relevant quality measures as a means to continuously improve patient outcomes. To be successful as a hospital-based value program provider, critical access hospitals will need to ensure that competent people and sound processes and technology solutions are in place to properly collect, report, analyze, and take action on quality